Today we're going to continue with what we started last week. It's going to be in techniques in 3D planning part 2, or you may call it advanced 3D planning. So I am starting right now, and it's 5 minutes past. Okay. All right, so we're continuing 3D planning techniques. Last week we covered some of these concepts, part 1, and today we're going to continue on this. Let's see if you remember this question. So this is a question that we saw last week. Can we start the Zoom poll, please? So the best 3D conformal plan has fewer fields, whatever works for 2D works for 3D, has more fields, the more the merrier. We should have more than 3, but not too crazy. Or maybe we use a smart combination of different energies, wedges, field and field, non-coplanar. And we have a very active participation this morning.
All right, I'll give everyone a couple more seconds to fill out your answers.
Yeah, I'm loving the answers so far. So yeah, Kaylin, I guess we can end poll right now. And so and share results. Right. So this is actually correct. Everyone, C and D is good. D is more comprehensive. So I would choose D as the answer of choice. Fewer fields. So the problem with fewer fields, you don't get conformality. Anything that is 3 or less, you would get maybe like a triangular shape, or 2 is parallel opposed beams, and single beam is single beam. Some people might argue 4 is also non-conformal, because if you have a 4 beam, such as prostate, box technique, or anything in the pelvis box technique, your isodose profile will be a square shape. You have like 2 parallel opposed APPA, 2 parallel opposed lateral, you get a nice square. And so you do need more fields than that. And then with the uses of, what we said, field and field, couch rotation, etc., then you can get that extra level of conformality. All right, so we mentioned that the best way to create a 3D plan is looking at things in 3 dimensions. And one of ways to do that is what we call the beam's eye view. So you're looking as if you are the beam going through the patient and then seeing what you could avoid. And by changing your beam eye view angle, then you could figure out the best, couch gantry combination that you can avoid. We also mentioned the field and field technique, which is using multi-leaf collimators, the MLCs, to remove the hotspots. So you do this manually, right? You look at the volume, you see the hotspots, and then you create a field with MLCs that's covering the hotspots. And I said we use that for breast most of the time, but it can also work. And to give an example, in our institution, we use the field and field technique for whole brain irradiation. As you know, the brain is not a perfect sphere. It's, more of an elongated egg shape. And we're prescribing to midline. So the monitor unit is calculating to midline where the brain is thickest, but then we have the thinner parts of the brain. How do we handle that? So we do use the field and field technique for whole brain. So think of if you are using 2 parallel opposed beams, that also includes the tangential beams for breast. What can you do to make things more conformal, or at least reduce the hotspot, increase homogeneity? Then definitely you can use the MLCs in a field and field technique. Now, I do remember we ended last week with requests to see live illustration of how this beam eye view looks like and how I can use it to create or to choose angles. So I'm going now to switch to my clinical workstation. I will ask everyone not to take screenshots. The presentation will be made available to you later on with any identifiers blurred out. So we're going to switch screens.
And Shada, while you're switching screens, do you mind, Amara was asking if you could explain field and field a little bit more?
Oh, okay. So field and field, you have your main lateral beam, right? So in this case, let me go back here. And so I'm doing whole brain. I'm treating whole brain. And we do that with two lateral beams. Now, one beam is coming from left lateral, the other beam is coming from right lateral. And when you do the calculation, you see that you have hotspots all over, right? Because we are calculating to here, to this point. Usually it's a point around the middle of the brain. And most likely it is going to be your isocenter. And this is the thickest part of the brain. Now, when you do your monitor unit calculation, what you see is that you'll have hotspots, superiorly, maybe posteriorly, where the brain becomes thinner. There will be hotspots, meaning there will be doses more than 105 or 107%. And in those cases, how can you remove them? Yeah, you only have two parallel opposed beams. And wedge will not work in these scenarios because the hotspots are everywhere. They're not in one direction. And so what we do, we copy the original field. We create a subfield, so to speak. And then we use the MLCs to go inside and cover the hot area. So you could see here, this is, let's say we're covering 110%. So you put in your MLCs to cover where you see 110% doses. And maybe you give that subfield, 3% or 5%. Now, remember, you need to do the same thing from the other side. You want to keep things, parallel. And then let's say now we are down to a lower hot doses. Then you copy again the field and you create a subfield or another field with more MLCs to cover the next level of the hotspot you want to remove. So this is what we call the field in field technique, right? It's basically using why do I have my hand up? I just realized that. So using the multi-leaf collimators to absorb the extra doses. Your original field, the left lateral, is still there with the highest weight. So maybe you give it 80% or you give it 90%. And then you have the remaining 100%, the remaining weight to go to those subfields. So maybe this will get 5%, this will get 3%, etc. So by this, we are reducing the hotspots in a plan that only has two fields in it. Is this clear? I hope it's clear.
That was a great explanation. Thank you.
Okay, appreciate that. So now let's go into, all right, you should all be able to see my clinical screen. Okay. And if you remember, this is something similar to what we talked about last week. So this was a case of, we have a tumor or we have a lesion or an area we want to treat sitting right next to the eyes, to the left eye in this case. And then we asked, how would you treat this? And we heard, we heard good examples of maybe we use wedged pair, which would be something we do in 2D era. We heard about using 3 fields, maybe wedged pair and 1 lateral. And then we also talked about non-coplanar beams. Now, it is very difficult to imagine how I would rotate the couch in order, let's say, to avoid the optic chiasm. Anything I do in 3D, if I come from this angle, wedged pair, you will see the chiasm. If I come lateral, you'll definitely see the chiasm in the path of your beam. And so we introduce a concept of non-coplanar beams. Now, for this, depending on your planning system, you should have, if you look, to the right side of your screen, you should have a screen that has maybe 3D view or beam eye view, etc. So this screen would show you the tumor in space, in volume. And then, of course, you can move it around. So, maybe a non-coplanar beam that's coming here will irradiate the tumor and completely avoid the optic chiasm. So the optic chiasm is the one in purple you see here, and behind it is the brainstem. Maybe we can think of another angle from this side with couch kick over here. So this is irradiating the tumor and then avoiding exiting through the other eye, avoiding the chiasm, and also maybe we can avoid the ipsilateral eye. But how would you, if I give you this angle, would you be able to tell me what is the couch gantry combination? Most likely it's very difficult. And so we would go to something called the beam eye view. And let me just turn on my beam that I want to use. Okay. So this is a beam that I created, randomly, and I want to see, and again, depending on your planning system, you could control the beam either from the window of the beam eye view, or you can control it by typing in numbers here, right? So depending on what you have. So in this particular planning system, I can control the view using the window. And then I start going, all right, let's rotate. So now I'm rotating. If you notice in the corner, your lower right corner, you see the gantry. This is the linac and this is the couch. And then you see that I can, go out. So this is going around the patient. Couch is 0. So this is everything I do here are coplanar. So starting from gantry 0, if I rotate in any angles, I am exiting through the other eye. Or maybe, you know what, maybe I found an angle here. So this is beam eye view, right? I found an angle here where I am avoiding the optic chiasm. So that's a good angle. I'm going to keep it. Okay, now what do I do? Then I could start figuring out the best way to rotate the collimator. So remember we said in 3D planning, rotating the collimator would help. Because instead of, if I have the collimator sitting right here, it's abutting the chiasm. And of course I can make it smaller, but then I'll be kind of, too close to the PTV. So if I rotate, same collimator size, I did not change the size, but I'm rotating. So I introduce this distance to the chiasm. So that's, for example, one angle. And if I want to see what that angle is in this planning system, this would be gantry 142.5. That's a little bit too much. Let's just do 142. And your collimator rotation is 11.6. I can make it 12. But you would never think about these numbers if you're just, going off, rotating around the patient from 2D point of view. I can also continue. Let's see if I can add another angle. So now this angle is posterior, but not PA 100%. So you could see here on your lower right corner, the gantry is PA, but the angle is actually 178.5. I can make it 178. And then you could also see what is the best collimator angle for this one. So what I do is that I start by finding at least 4 to 5 beams. So this would be like a second beam I would add, right? And then I would go on and find a third and fourth beam. And now I'll show you the couch kick. So you start by finding 4 or 5 beams that are good, that are focusing only on the tumor. And then you think about adding wedges or field and field. Let's introduce, 40-degree couch angle. So you could see the couch on your lower right corner. You see now the couch is rotated and I gave it 50, for example. So what happens now if I rotate the gantry around it? So now this one over here looks like a good option. Let's go couch maybe 60 degrees or 70 degrees. So I like this one because I can also go off the optic chiasm. And I want to, you can start by creating, and of course, with your planning system, you can automatically create the block and tell it how far away it goes out from the PTV, depending on all the options you have. Now, do I need to find a different collimator angle? Maybe, maybe not. Maybe it's not very important here. If you're adding a wedge, and if your wedge is dynamic wedge as in Varian or motorized wedge as in Electa, so the direction of the collimator is important. So let's say this would be a third beam I would include. Last week in the example I show you, I had a couch 90. And I think gantry was 0 if I remember. No, gantry wasn't 0. Gantry was something else. Gantry was probably around 80 or 90, like a true vertical, a true cranium field. But I don't like this angle because you see part of the eye, the ipsilateral eye, which is shown in blue, very difficult to see, is in the field. So let me see if I can find another angle where I can avoid the eye. I'm going to go back to couch maybe 70 and then rotate this if I can find something different. Yep, this is not a good angle because the exit is through the eye, and now it's seeing the entire optic nerve. And this also is not a good angle because now the entrance is through the eye. So now
Shada, we have a quick question.
Sure.
People are wondering, when you're making your field, I had a couple questions asking about how you set the boundaries, wondering why there's more space around the PTV and why it's not close to the edges.
Oh, yeah, remember ICRU 60 that we talked about? I'm sorry, ICRU 52 that we talked about. You have to make sure you give enough distance from the edge of the field to the PTV to build up to your prescription dose. So at least give it 5 to 6 millimeters for the penumbra. However, and we mentioned this, right? If I have 4 or 5 beams, I can afford to be strict on one side. You know, for example, I can bring this edge, the Y2 edge, I can bring it closer here to avoid the other eye, because I know even though from this field, I'm cutting the PTV short, you know, it's at the edge, but the other fields, I have 4 other fields, for example, that are irradiating this volume. So with 3D planning and the more beams you use, you can afford to be tighter on your PTV to field edge. This is not true if you only have like 1 or 2 beams. If I only have 1 or 2 beams, if you cut the PTV on one end, it will show, like you'll see a reduced dose. So, you know, this is an illustration of how you can use the beam eye view. So sorry, my internet connection is slow, so you're seeing it struggling to update. But, you know, at least we were able to find together 3 beams, couch 0, and then I think we had like 2 good beams, couch, not 0, different couch angles. And then you can go on. The more beams you add, you would be able to create a more conformal plan. Okay, let me reduce this. It's becoming too slow now. So as I said, this definitely is not a good angle because it's going through the right eye. But we were able to create multiple angles. And sometimes those gantry angles, it's something we'd never think about. Like the one we had with 142 degrees angle, and I forgot collimator rotation was 11, I think. Something like that. You know, you would come up with, or I forgot the numbers now, you'd come up with so many different rotations that you can really have a good conformal plan. The one caution is that don't get too excited. For example, let me show you this. And you tell me if, wait, it's a little bit slow, apologies. Let's do this. And let's do this. Okay, wait, the other way. And I'm going to correct for this one. What's wrong with this angle? This is like a severe case. Let me just make sure that I include the PTV. You know, raise your hand or maybe write in the chat, what do you think is wrong with this angle? Or hold on, let me go 150. 150.
Rashid says in the chat, exit beam.
What's wrong with the exit beam?
If you'd like to answer, you can raise your hand or briefly unmute yourself so that you can answer as well.
So exit beam, yes, because we're exiting through the ipsilateral orbit. What do you think is wrong with this angle, technically speaking? Can we deliver this angle?
Because of collision alert, actually. Sorry,
I'm sorry?
collision alert.
Oh, 100%. This angle is not deliverable. Because if you look at this icon over here on the lower right side, you are colliding with the table and the patient. And so when you begin 3D planning, you would get too excited about, oh, I found and I've done this back in the day, like 22 plus years, like I found the perfect angle. And I was so happy. And I did those calculations and the plan was perfect. And then my senior was like, yeah, but you just killed the patient. You crashed into the patient, right? Now, luckily, modern day Linux, they have collision alert, whether you're using Electa or Varian or maybe other vendors. When you go and actually deliver the plan, it will tell you I cannot go further. Collision interlock will be activated and everything stops. But in the planning system, you don't see that. And if I want to go ahead and calculate it, it will give me what I ask it to give. So remember, computers, while they make our life easy, they're not smart. So I could just go ahead and deliver a plan that would crash into the table and crash into the patient. So if you like computer games, and I know most of you, like at least a physicist, right? We like computer games, you like to play computers, etc. And you could see here how this beam, the beam that we just chose, it's like you have to go through the entire patient to deliver that angle. So you would love using the beam eye view, you would love finding different combinations of gantry and couch angles you've never thought of before. And the plan would look wonderful, but make sure you're not crashing into the patient. So I want to go now back to the presentation. So this was an illustration for beam eye view as requested by some people. You requested this last week, so I hopefully showed you how to do that. All right, so now we want to go to something that you're already doing it in 2D. And, oops, sorry, I forgot to turn this on. And once you go to 3D, it will confuse you. It is very intuitive. Physics-wise, it's intuitive. The physicians also know about it because they've studied it. But when you see it the first time, you're like, what is going on here? And I will go through the principles in the slides, and then I will switch to show you in real life what we're talking about. And that's basically photon-electron match. It sounds easy, and it is easy, but once you see it in 3D, once you start doing CT-based planning, it will make you scratch your head a little bit. All right, so we do know how the isodose line of single photon beam look like, right? It's their nice straight isodose lines with 50% following the beam edge, and then very tight penumbra, right? And we also know how an electron beam isodose look like. The lower isodose lines are spread sideways, and you can see them here. They're spread sideways on both sides. And then the 100% and the higher isodoses are kind of tighter. And you've done this all the time. When you're treating head and neck, you have parallel opposed beams for phase 1, and then you go off chord for off chord phase or phase 2, and then you match with electrons. When you're doing 2D, you don't really see what's going on inside the patient, but you do know that you will have a hotspot when you match photon and electrons. And we're matching here on the skin because this is what we do, right? We match electrons with photons on the skin. Turn on the light field, we draw the photon beam edge, turn on the light field, we draw the electron beam edge, and we start moving, the electron field to match with the photon field. But what's happening inside the skin is that the bulging of the isodose lines of the electrons will add up to the dose of the photons, and then you have this hotspot. We all know this from physics. Now, when you see it, again, as I said, this is things that I've gone through over my career. Is like, why do I have a hotspot here? And then I'm trying to put a wedge, I'm trying to put MLCs. and it's not going away. And it's because of the physics of it. It's not going to go away. Your electrons will always go into the photon field, and you will have a hot spot inside the photon beam. So you think you might need to use a wedge, like, you know, I need to put a wedge here or something. No, it's not going to remove it. Wedge is not going to remove it. All right, so now I'm going to switch and show you. And I'm doing a head and neck, parallel opposed beams, off chord, and then with electron match. I will not do the full plan. You know, I did something quick yesterday. I will show you the result, and then we'll put the match and we see what's going on. Okay, so I'm going to go back again and share screen 3, this one. Okay. So we are back to screen number 3. I need to open. It's running a bit slow, so just bear with me. Okay. So phase 1, parallel opposed beams. I'm prescribing 2 gray. Let me show you first of all what I have. I created some lymph nodes. I created a PTV neck. Let's remove these guys. So I created like right lateral PTV. So this would be where your PTV lymph node is. And I'm trying to irradiate this with the parallel opposed beams like we do in head and neck. Okay, so I have that. And I created these 2 beams. I put a little bit of weighting. Let me just do this. And we're prescribing 2 gray. All right, so this is 2 gray. Usually in your head and neck, of course, you have bilateral lymph nodes, or sometimes you have just one-sided lymph node. So that would be irradiated to maybe 66 gray for phase 3. But, you know, for this example, and notice where the hot spot is right now. It's more anterior. My prescription is 2 gray. I'm delivering 2 gray, and I have a 2.2 gray hotspot. So that's like 110%. And there's a reason I'm not removing this. I'm keeping it. So this would be phase 1. Now, if I want to go ahead and deliver full irradiation, I cannot do that because there's a spinal cord in the path of the beam. Now, going to the DVH, let's see how much the spinal cord is getting just from the parallel opposed beams. So that's the PTV neck, and that's my spinal cord. And the maximum dose of the cord is 1.9 gray, like the maximum point dose. You can see it down here. Or if you usually use absolute volume, that would be about the 0.03 cc. So yeah, 1.9 gray, 0.02 cc. So the cord is already getting almost full dose. My prescription is 2 gray, the cord is getting full dose. So then how can I proceed further to deliver the full prescription? You know, we have still go to 66 gray, maybe 70 gray, depending on your treatment. Definitely the cord will get much more than expected. And so what we usually do, we do phase 2, which is off cord. You have your photon beams in the exact same position as you did, but now you cut them short at the off cord, you know, at the cord level. So, sorry, it's taking a little bit of time to update. All right, and let me show you the 2 gray now. All right, so this is now 2 gray. This part of the PTV is not being irradiated because we have it covered, and we're only irradiating this. Now, what do you usually do? You would irradiate this with the electrons, and this would be phase 2 electrons, right? So this is usually what we have. And sometimes, and this is my 2 gray, so 2 gray is covering, if I put maybe 1.9 gray. So it's covering what's in the path to the spinal cord. So it's covering this part. I did not bother to put a lot of blocking just to show what we're doing. Now, how do you do the match? You make sure that the electron beam light field starts with the end of the photon field. And in 3D planning, you can do this by matching the edges of the beams. Yeah, I know people are probably asking, how do you do that? So I'm coming to that. If I don't answer your questions, this is really slow. All right, hold on. I'm making it bigger. Okay. All right, so in this planning system, the yellow, the bright yellow is the field edge. And what you're seeing here, you're seeing the edge of the right lateral beam. So this is yellow. And as you could see, it is not irradiating this part of the PTV. Now I will turn it off and I will turn on the electrons because I want to explain something. So the, electrons come in cones or applicators, 6 by 6, 10 by 10, 14 by 14, or 15 by 15, depending on what you have, etc. And then you have to create a block. So this is a 6 by 6 applicator, and you can see this is the isocenter in the middle. This is the yellow one in the middle. And the yellow here is the beam edge or the applicator edge. And I created a block. What the block is shown in orange or like brown orange. So this is the edge of the block. And the idea is that we want the edge, we want the electron beam to start where the photon beam ends, right? We're matching on the skin. So how do you see this in your planning system? When I turn on the photon beam, I will see the orange, the block from the electron is following the yellow of the photon beam. They're matched together. Okay, you have to bear with me. This is running a little bit slow. And there are different ways of doing it. You could do it with your electron beam turned on. And then when you create the block, so in this case, you could see this is the electron beam, upper right corner, and the block is the shaded color. And you start changing the block size. I could draw a larger block or a smaller block. And if I click here, this will change. So for the sake of illustration, you see how now it's changed. The orange is not meeting with the yellow. You see where my cursor is, right? So, and some planning systems will allow you to do this on the skin. You go to 3D view window, and then you could see the skin, and you could match the two photon electron on the skin, depending on what you. Yes?
Lydia's asking for some clarification. Is this like a physical block?
Yes, yeah. This is a regular electron block, yes. All right. And so this is, if you want to do an isodose distribution of photons and electrons together using CT-based planning, you have to match the photon electron on the screen just like you do in real life. So with the field lights, right? And as I said, no, I changed the reason I created a different, I made several copies. So if I, screw up one copy, that's fine. I can have other copies. So I showed you how by changing the size of the block here, then you could see that the block is not now matched with the photon field. All right. So going back, I did this photon field, parallel opposed, of chord. It's too slow. Come on. Looks beautiful. I have 110% hotspot towards anterior. And then we created this electron phase 2. Again, looks good, looks beautiful. I don't have any hotspots. It's not like the 2 gray is nice. And then what happens when I add both of them together? So for this, in this particular planning system, I have to go to a different window.
Then could you also clarify, Shada, why we are using electrons for that bottom part instead of covering the whole thing with photons?
Yes, because in head and neck treatment, the tumor requires higher than 60 gray of prescription. Usually it's 66 gray up to 70 delivered over 3 phases. With 3D planning, we're only using 2 parallel opposed beams, which means that the entire path between the left and right beam will get the full prescription dose. And so in this case, your spinal cord, and we're talking around cervical spine, the upper cervical spine, they will get 60 gray minimum. This is really higher than the tolerance of the spinal cord. You know, anything higher than tolerance, you will be damaging the cord, and patient will most likely go into quadriplegia, and you know, it's a life-altering situation that could lead to death. So when we're doing head and neck treatment with parallel opposed beams, we do it in phases. Phase 1 to 45 gray, so just below cord tolerance. And then we go phase 2 with the photon beams, avoiding the cord, but you'd still have the issue with, what do I do with the PTV that is posterior? And so in this case, we use electrons because electrons do not go further.
Great, thank you for that explanation.
Thank you. And let me, where's my screen? It kicked me out of the screen when I changed. This is interesting. Okay, so we're back sharing this one. For some reason, it kicked me out of it when I changed. So now let's add photon and electron together. Okay, I have now added both electrons and photon. And our prescription is 2 gray. And as you could see, this is, you know, this is really beautiful. I have 2 gray covering the entire region. This is the PTV here is hiding behind the color wash. 2 gray covering if, you know, you usually have lymph nodes also extending posteriorly, or if not, you add another block here to stop the electrons. And then your spinal cord is covered, it is safe. But what do we have here? Now we have a 3.3 gray hotspot. So remember, our prescription is 2 gray, but now there is this tear-shaped hot area. And look where it's appearing. It's appearing under the photon beam. And this is what we talked about, is that because electrons, they bulge, the isodose from the electrons will go inside the photon beam and they create a hotspot. Let me remove the electrons, and then you see the hotspot now is inside the photon beam. And honestly, there is no way for you to remove them. Because having photon alone, you have a perfect plan. You have electrons alone, you have a perfect plan. If you try to add a wedge or MLCs, you'll be underdosing everything else in the path of the beam. I mean, you could try if you want. So someone might ask, what if we don't match at the skin? Because now we can see what's happening inside the patient, right? And this is the reason why when you're starting phase 2 of your head and neck treatment, your patients will have a lot of skin arrhythmia. You'll be delivering much hotter doses to the skin. Their skin will get very sensitive. It will react. And there's nothing we can do about it. And that's why once you bridge into IMRT planning, IMRT is best for head and neck because you don't have to deal with electron photon match. And it's something we talked about when, like back in the day, we went from 2D to 3D and we started realizing, oh, what we see in the book, in the physics book, we're seeing it live here in the patient. It happened before, but we didn't see it. Now when you see it, it becomes more real. So a concept we said, maybe if we don't match at the light field, maybe if we keep a gap. And I want to show you what happens if we keep a gap. So I created another plan sum, and I'll show you the gap that I created. Give it some time to update. And let's go back to 2 gray. Yeah, you see, I created a gap here, and it is about barely 2 millimeter on the skin. Like 1.7 millimeter, not even 2 millimeter. And you could see how we have now this dip that, you know, depending on how you set up the patient, this is not a perfect scenario, but you see, creating a gap on the skin will not remove the hotspot. The hotspot is reduced. We went from 3.3 gray down to 2.9 gray. So there is still a hotspot. And we're talking about a considerable hotspot. It did not go away. It reduced somewhat in value, and the volume is reduced. But now I'm introducing underdosage of my PTV. And this is with barely 2 millimeter gap. So instead of matching photon to electron at the skin, I created this extra gap. You can see the orange is the block from the electrons. And you see now there's this gap towards the photon field. And so this is real. And we know it happens whenever we match photons and electrons. We know that it happens, that we do have a hotspot within the in the match. It's just when we don't see it, it doesn't feel real. It feels like a physics concept. And so every time you're doing photon electron match, and sometimes when you're just going into 3D planning, you would do everything photons on the planning system. And then with electrons, you just do, oops, I apologize. Sorry, my video is off. It's when you start doing 3D planning, you'll do everything photons on the planning system. And then you keep the practice of electrons being just, pen and paper. Okay, so we will use 6 by 6 or 10 by 10, we'll put this block here, and then what's the monitor unit we need? So you see them separate. You still use, and again, this is a natural progression of things. You use planning system for photons and you keep electrons as separate. And then slowly, you start adding both of them. But once you start adding them, it becomes uncomfortable because now you are seeing the hotspot. And now you have to take action. Well, the hotspot has always been there, right? We just haven't seen it before. So where do we see electron photon match? We definitely see it with head and neck treatment. We see it with breast treatment if you're using electrons to match for the intramammary lymph nodes, and with the two wedged pairs, and anywhere else. So any questions so far? So we've talked about BMI view, field and field. We did a recap, and now electron photon match with 3D planning. Before I proceed to the next topic, any questions?
Vincent had a quick question. So matching electrons usually creates hotspots on the match line. So first they had a question about asking how much gap you need to put so there's no cold or hot spot. And then second, after treatment and the patient presents with recurrence along the match line, does that potentially create an issue?
So I do not recommend any gap. The reason is a slight gap would not remove the hotspot at all. It will just make it like less in value and smaller in size. But you'll be underdosing your PTV. Remember, the reason we are using electrons because the PTV is shallow. The PTV is, lymph nodes, and there's somewhere here in the skin area, under the skin. And because we have, a spinal cord here, so this is my spinal cord, we cannot keep delivering with photons, so we have to switch to electrons. Any gap you create along the skin will give you underdosage for your PTV. And I showed you that barely 2 millimeter gap gave me this dip in the 2 gray. So the question is that this is for physicians. As a physicist, I'm going to tell you, I don't recommend underdosing the PTV. However, this is a question now back to the physician. How much underdosage you're willing to have for this patient. And if this was a uninvolved lymph nodes, meaning that they're going to go to 50 gray or maybe 55 gray at best, this is just a recommendation, is that maybe you could afford to underdose them, like 90% of them get prescription dose maybe, or 95% get prescription dose. But if those were involved nodes and your intention is to take them all the way up to 60 or 66 gray, then underdosing them would compromise treatment. And the hotspot, as I said, the hotspot has always been there, but we haven't seen it. When you're in the 2D era, you're doing parallel opposed beams, prescribing maybe to midline, and then separately you prescribe with your electrons. You do it on pen and paper. You haven't seen the hotspot. But now you're actually doing it on the screen with the isodose line and you see them. And I know it's scary and you need to take action. The action I defer to the physicians who is treating the patient. Creating a gap, and if you go back to the book Physics of Radiation Therapy by Faiz Khan, chapter 15, I believe, or 15 talks about electrons. And he has this scenario. So it's something that we read and we study in the book, but we don't see it because, you know, if you're in the 2D era, you don't really see it on the planning system. So the hotspot has always been there every time you're treating photon electron patient with a matched line. And so imagine now all the problems your patients have with their skin is coming from that hotspot inside the skin, and there's nothing we can do about it. That's my recommendation. Keep the match as is. If you want to create 2, 3, 4 millimeter, then you need to make sure exactly.
uncle jo aaye the.
I'm sorry? Oh, that wasn't the question. All right, and we're coming towards the end of the hour, so I want to go. If you want, you can send the questions in the chat. Kaylin, if we don't answer all the questions, can you please have a copy of them and then send them to me by email? I can provide answers later on by email because there's still other things I want to talk about here. So there's another technique that we talked about, but just quickly last week, which is using a single isocenter. Right? So using a single isocenter for, let's say, breast field with supraclav, and also maybe using a single isocenter for cranospinal irradiation. Why would that help me? Once we go into 3D planning, you'll start appreciating single isocenters more. And also you could use single isocenter for head and neck. I would have the isocenter, for example, somewhere here on the suprasternal notch, and then close the upper jaw, open the lower jaw to treat the lower neck, and then close the lower jaw, and then open up here and treat 2 lateral beams. So why I am going through all this trouble? All right, so let's see now what we have. And as an example, I'm going to give you cranospinal irradiation. So the conventional technique is we use 1 isocenter for the cranium and 1 isocenter for the upper spine. So it's something like this. I have 2 lateral beams irradiating the cranium, and I have the PA beam irradiating the spine. Your patient is either prone or supine, however you do it in your clinic. Now, again, we do know that radiation diverges. We do know that. And Khan in his book, or any other book, not necessarily Faiz Khan, they talk about when radiation beam diverges into each other, you create a hotspot, and that's what we see here. We do have 2 hotspots created on the side of the neck when the lateral beams from the cranium diverge into the spine. So now what do we do? And you would find, again, the solution in the book. This is just a quick reminder, is that, well, we need to rotate the couch to match the divergence of the beam. And the angle is the angle of divergence of the cranium beam. You do it on both sides, and there's equation. You can ask your physicist to do it for you. For the physicians, you don't have to worry about this. All you need to know is when I treat the cranium beam, when I treat the right lateral cranium beam, the couch has to be kicked towards the gantry by an angle equals to this angle. And when I'm treating the left lateral cranium beam, the couch has to be kicked again towards the gantry by an amount equals to the same angle, right? So this is, when you do that, this what would happen is now with these couch kicks, you match the edges of the 2 fields with a spine. So now we're done, correct? We were able to match, we were able to remove the divergence of the cranium beams into the spinal field. But we still have another problem. The spine field itself is now going inside the cranium. And you see it here. So depending where, you know, the edges of your beams are, the exit is usually around the lower jaw. So it's either the upper neck or you're exiting from the oral cavity. Both are bad. And in this case, what we do, the cranium beams are rotated to match the angle. So we rotate the cranium beams and you have a nice match. Too many rotations. What happens if someone rotates on the other side? Then you have a big problem. And so the idea of a single isocenter, or sometimes people call it half beam block. I think I heard one of the colleagues last week, they said, we use half beam block. So either a single isocenter or half beam block is that the use of a common center will remove the issue of divergence. And this is the physics of radiation. So the radiation diverges everywhere, except on the central axis. On the central axis, the radiation is going straight ahead. So if I can match both beams in one point and use a single point as isocenter for both, then you don't have to worry about the divergence. You would worry about setup, and you need to do something called feathering. But that's not the issue of this lecture, right? So you still have to worry about uncertainties in setup. And so, as I said, now in one area, in order to treat the spine field, you close the jaw here at the isocenter, you treat the spine field. But since now the isocenter is blocked, and if you remember from ICRU, I cannot use this point anymore, then I have to create like a prescription point somewhere here for my spine treatment. And then to treat the cranium, we close then this jaw. So the lower jaw is closed. And then I create another prescription point in the center of the brain, and then I treat the cranium beams. And you do something similar with if you're treating tangential breast, supraclav, or head and neck. For breast and head and neck, I have seen clinics that do not rotate either the couch or the collimator. And that's okay, because it's not okay. The hot spot will be there because of the divergence and one beam going into the other beam. For head and neck treatment, it will be in the soft tissue. So that will add to the hot spot that your patient suffer from. For breast, when I'm doing tangential and the supraclav field for the breast, the match will be deeper in the soft tissue. So you will not see it on the patient's skin, but it is there deeper. It might add to, patient complaining from, pain inside their arm or something like that. So keep that in mind. Any questions so far?
Feel free to raise your hand or unmute if you have a quick question.
I don't see any hands raising. All right, good. So now the final part, I know this is maybe too much to take in. So if you think of any questions, please do send them either here or by email to your RCC volunteer, whoever, I think Kaylin or Emily, whoever you receive emails from, send them those questions and they will forward them to me, and then I can provide answers later on through emails. All right, so the last part is, how do I now, I have two plans. I have two nice 3D plans. How do I choose which one? DVH versus isodose lines. Which one do I use? Which one is more important? Do I only concentrate on looking at prescription dose, like 100% isodose line, 90% isodose line, maybe 95%? Or do I worry also about the 50%, 30%, 20%? Now I have to switch back to the clinical screen, but anyone wants to tell us what they do in the clinic? Do you go, especially those who already switched to doing 3D planning? You could raise your hand or you can type in the chat. Which one is more important, DVH or isodose line? And how do you start? Do you start by looking at the DVH, or you start by looking at the plan itself? And do you worry about 50% or 30% spread? Anything in the chat or raise your hand?
Rashid says prescription dose.
So you only look at prescription dose coverage, okay? Abed, I see Abed raising his hand. Abed, do you want to unmute and tell us what you do in your clinic?
In our clinic, actually, what we are doing, we are going through the first isodose levels first. Then we are going
Okay.
and checking the DVH, actually. Both of them are important for us, like vice versa, actually. But first, we are starting with the isodose lines and the splash and all. It's great. Then after that, we go to DVH.
So I want to ask you, what do you look for when you're looking at the isodose plan? What do you look for? And then when you go to the DVH, what also do you look for? If you can give
So
us
the
more details.
So the important part is actually our criteria is like 95% of dose is 100% of volume, and
I'm
secondly
sorry, 95% of those is going to
95%
okay.
95% of the dose should be received by 100% of the volume or 95% of volume, 100% of volume actually.
Got it.
And secondly, the last 50% isodose line where it's touching, where it's going. This is what we are checking to the isodose levels, and then and one important thing what we are checking also, like the point dose actually. Sometimes we are checking the point dose. It should not be more than 120 or something like this. I don't know what's the complete, like it's 120 or something, but it should not be more than 120 point dose. Yeah, this is what we are checking with the isodose levels. And the DVH at the last, we are checking like how much dose, like the V20, V30, like the criteria, according to criteria, how we are getting and how much the PTV is getting as
So
prescribed.
I want to ask you, Abed, all these things that you mentioned, that the 95% isodose is going to 95% volume, the maximum dose, all this you can get from the DVH. So why bother with the plan itself?
Actually, we can't get the point dose. Can we get the point dose from DVH?
Yes, the point dose you can get from the DVH. I'll show you now. So depending what your planning system is, you should have different columns in the analysis of the DVH, minimum, maximum, mean, and you can also personalize it. So, just explore a little bit more with your DVH options. But yes, like everything you told me now, I can get from the DVH. So why should I bother with the plan itself?
Good question.
Good question. Yes. Oh, so we're going to talk about it right now. I know the hour is over. We have until, 30. We have still 30 minutes, and we can use the 30 minutes to go through. I have two plans. We'll compare them together, and then we'll see which plan would you choose. Maybe we can ask people in the chat.
I guess.
Kaylin, I see people writing in the chat.
Yeah, we have a lot of people that are saying, looking at both isodose lines and the DVH. That seems to be a popular consensus in the chat.
And I agree. We have to look at two. The question is, what is the information you're looking for when you look at the dose plan? Because everything you can coverage, for example, 95% coverage to 95%, volume or 100% volume, I can get that from the DVH. And I see the last one. Oh, absolute doses. Absolutely. I always look at absolute doses. I never look at relative doses, whether in DVH or in the plan itself. Because looking at relative doses one time created a large safety issue for a patient when we started 3D planning. So now let me share screen.
Real quick, Michael, did you want to comment as well?
I'm sorry, I didn't see anyone. So someone, okay, yes, please, if you have anything to comment on, please unmute yourself and.
Can you hear me?
Yes,
Yeah,
we can
I'm
hear
sorry?
you.
Yes.
Yes,
So
go ahead.
my clinic, we have to concern with the plan to check the coverage, the consistency of the isodose lines in the plan. The
Okay.
DVH can tell you it will give you like 95% getting 95%. But if you check through the plan, through the slices, you find that the coverage is not so much consistent. So that's why you have so much to be concerned with the coverage with the consistency of the isodose lines in the plan.
I hear
Thank
you.
you.
I agree with you 100%. And what you said right now, I'm going to show. It took me some time to create these two plans because I wanted to show kind of a DVH. And using the DVH, people might say, oh, I want to choose this plan. But then when we go to the isodose plan itself, they change their mind. Or I think people will change their mind. So I am sharing screen right now. And what I have here, I have created two plans. Can you see my clinical screen?
Yes.
Okay. So two plans, plan 1 and plan 2, and that is the same one that we saw for the brain, with a large PTV sitting right next to the left eye. And I'm going to call them plan 1 and plan 2. And the prescription is, if I remember correctly, is 40 gray. We'll see it now. All right, hold on, I'm scrolling through to find what I want. Yes. All right. So PTV. Plan 1 is the squares. Plan 2 is the triangle. Oh, wait. I forgot to save yesterday. Hold on. I'm going to stop sharing for a minute. I created some changes that I forgot to save. I want to save them right now. So this is plan 2. Just bear with me a little bit. This is plan 2. All right, let's go back to sharing the screen. All right, so looking at this screen, prescription dose is 20 gray. And I have two plans. Plan 1 is the square. So you can see plan 1 here is the square. And plan 2 is the triangle. Now, they were created such that they share the same point. 20 gray is covering 97% of the volume. So you could see here, this is 20 gray, and this is 97%. So I'm going to say the coverage is very similar. Now, plan 1, the squares, is colder. Plan 2, triangle, is hotter. Let's say, based on this information alone, which plan would you choose? And, just quickly write in the chat. Plan 1 is the squares. Plan 2 is the triangle. They both have similar coverage, but plan 2 is hotter.
We have one vote for the square plan.
I would use the square plan because it's colder, okay?
Several people have said plan 1. Nada mentioned plan 2. Overall, it seems like we got a lot of plan 1s.
And even the CTV coverage, I turned on also the CTV. So you see the CTV in orange. They both have both plans. Like if you look up here, they share the same coverage. So CTV is more than 100% covered with 20 gray. But then plan 1 is colder, so it drops off to 22 gray. Plan 2 is hotter. So just looking at PTV coverage, we are going to choose plan 1. Okay, now I'm not going into organs at risk yet. I just want to show you PTV coverage in 3 dimensions. It's that is too slow. Oh, come on. I will remove this back clutter, like background clutter over here. I will also remove this. All right, and syncing both. So plan 1 that everyone shows is this one. So this is on the left side of your screen. Plan 2 that no one liked because of different reasons is on the right side of the screen. Wait, I'm trying to reduce this. This is too slow. Right, apologies. This is becoming too slow here. All right, much better. See this. And let's go inside the PTV. Okay. So let's turn on 20 gray. All right, it's 20 gray. So again, this left side of the screen is plan 1. Right side of the screen is plan 2. And what you see here is 20 gray. So 20 gray is showing in blue. And then as you go from blue to green to red, you're going in higher doses. Now, as I scroll through the plans, keep an eye on both of them. I will scroll through slowly. I mean, anyway, my internet is very slow, so it's going to go slowly anyways. All right. So starting from here, going upwards, what I want to draw your attention to is what our friend mentioned. is that yes, the coverage looks equal on the dose volume histogram. Remember, this is like a single point analysis. But look at plan 1 over here. There is consistent underdosing in the same area. So this part, the posterior medial part of the tumor, it's consistently underdosed. And this is very close to the CTV. And if I draw your attention to the sagittal view, so you see where my mouse is, you can see that this entire part of the PTV is underdosed. And also the entire part of the anterior PTV is underdosed. So the DVH just tells you percentage of volume receiving a certain dose. And on this DVH, 97% of both PTVs are receiving 20 gray, so they look equivalent. But I'm looking at, there is a consistent underdosing in one area. Now, versus if you look at this plan 2, there is parts that, and this is 20 gray, of course, I can put the 19 gray or 18 gray, and then we look at them. You see, whether you look at it from transverse or you look at it from coronal or sagittal, so those are showing you the same points. The one in sagittal to the right side of your screen is compared to the sagittal here, but different plans. Now, coronal, in this particular view, coronal is showing that, this plan where my mouse is better. Let's see what happens if we go more posterior. Then you see here, this entire strip of PTV is not receiving 2 gray. It could be receiving 19 gray or 18 gray, but we're only now focusing on prescription dose because some people said they only look at prescription dose. So what we see here is that there is a consistent underdosing that would create a cold strip of PTV. Another thing to point out is something you don't see in the DVH at all. That is how much of your isodose line is going into the normal tissue. And this is normal brain tissue, right? So looking at this plan number 1, all these isodose lines, as I said, blue is prescription. And as you go light blue and green, we're going higher and higher in doses. So all this is dose spillage, prescription dose and higher in normal tissue. I do not see it here in plan 2, but I do see a little bit of strip here, a little bit of blue, which means prescription dose. Here, blue and green, green is higher dose. So green is like 21 gray. So this is your 105%, right? You don't get this information from the DVH as well. So now looking only at the prescription dose, in the DVH, both plans look equivalent for coverage, but one plan looks, oh, this is better, this is colder, I like this one. And looking at the, again, same, we're looking at prescription dose. Now you see a different story in the 2D and 3D representation. So we're looking at transverse, coronal, and sagittal. We do see a consistent strip of PTV being undercovered in the plan that most people chose. And I see a whole lot of prescription dose and higher being spilled over to normal tissue. So what you also want to see is the distribution of your prescription dose. And you'll not get the distribution from the DVH alone. I could be underdosing a complete strip over here, including maybe the CTV, but the DVH will tell me, oh, this is good. We still have 95% coverage, 95% of dose, right? But how is this covered? Now, another thing that if, let's say we go to 50% of isodose, I'm going now to 50%, which is 10 gray. Now we have a different maybe scenario to look at. 50% 10 gray has a lot of spillage for plan 2. And if you go scroll up or down, you can appreciate the differences between the two. This one being more conformal, like even the 50% isodose line is kind of following the shape of the PTV, right? It still has that like egg shape of the PTV. Here, you lose that. You have a lot of spillage. So that's something else to think about. Now, going into maybe the optic nerve, the chiasm, going into, you know, the other organs at risk that you care about, you could see how this now is definitely plan 2 has advantage. And that's what I didn't proceed to show, because it is important to understand, even with the prescription point of view, the DVH will not give you everything. If you're only looking at one point, 95% to 95%, or maybe 95% dose to 100% coverage, that will not tell you that you are probably missing an entire strip of PTV that you're not covering. Now, let me turn on other organs at risk just for a quick comparison. I know we're, you know, running out of time already. I'm going to put this here. And let's take, for example, the optic chiasm. So this is plan 1. This is what everyone said. We like plan 1. And this is plan 2. You see, it's much better for the organs at risk. And that's because this is more conformal plan. So this is done with 4 beams. And this is done with 3 beams. Now, 3 beams, all with couch 0. So all 3 beams are coplanar. This is probably something you were used to doing in 2D or started to do in 3D. This one is 3 beams coplanar, so exactly the same 3 beams as plan number 1, but I have a non-coplanar beam, you know, couch 90 degrees, and I forgot what the gantry angle is. So with 4 beams, one of them only, just one of them, being non-coplanar, I have a more nicer distribution of dose. Let's look at the involved optic nerve. So that's the left optic nerve. So even the involved optic nerve, you know, this one, the yellow one, that is part of it is inside the PTV. You could save it not only in terms of like a volume, but also in terms of maximum dose. You can spare it some agony. So it's going from 7.5 gray down to 6.8 gray. Other things, it depends on what you usually delineate. For example, here we have hippocampus. Let's see, hippocampus left. That's too dark. I cannot see anything. Even I cannot see the colors. Let me turn on hippocampus right. I don't know if you can see the dark color for the left hippocampus, the squares. So the more conformal your plan in terms of prescription dose and the 50% dose, or maybe you want to do just 80% dose, that's fine. The more you're saving your organs at risk. But now someone might say, you know what, I don't like 24 gray maximum dose. 24 gray is 120% hotspot. I don't like it either. So what can we do? Well, in this case, we have learned that we could use wedges or we could use non-coplanar beams. And in this particular case, I'm going to show you, I used both techniques. I mean, wedges, everyone uses wedges, right? So I have one field with wedge, another field with wedge, but this wedge is soup end, a third field with wedge, and all those are coplanar beams. Oops, or no, this is not coplanar. This is the third field with wedge. And then I have a, what do you call it? A non-coplanar beam coming from this direction. Let's get the plan. Okay, the easiest way to show you the non-coplanar beam is to go 5 gray. And now you see the effect of it. So if I go 5 gray, now you start seeing kind of the low dose volume. So you see there's a beam coming from, so that's the non-coplanar beam, right? Okay, so now what can I do to remove the hotspot here? I can play with the wedge angles. I can create field in field with MLCs. Maybe I can do that with a non-coplanar beam to remove the hotspot over here. So that would be the hotspot in this direction. Since this is in one direction only, a wedge can, playing around with the wedge angles or creating MLCs, the field and field, then you can reduce the hotspot. In this case, you have the best of both worlds. You have a conformal plan down to 50% isodose line, as well as with the MLCs and field, then you can remove this hotspot over here. So having a hotspot is manageable, right? Because then I have solutions for the hotspot. But having the spread of doses over here, whether it is the 50% spread or having a continuous and consistent, coverage where like this entire strip of PTV is being underdosed, that's a problem. Because with the setup of the patient, so now we're going now lateral, let's go more medial. So the underdosage dosage is medial. With, probably with the random setup of the patient on the table, with patient movement, maybe patient is losing weight, your mask is becoming loose, this underdosage might extend to the CTV. So I hope this shows the benefit of not being focused on just 95% coverage, 95% dose, or whatever different numbers you like to look at, but also how uniform is your prescription dose here, and how much of it is going to normal tissue. Like this is, this is honestly not acceptable. And then the continuous coverage versus, this guy. And yes, the hotspot is too much. 120% is too much. And so what we can do, play with the wedges, add field and field. Or I do remember one of your colleagues last week, he mentioned instead of one non-coplanar beam, they add another coplanar beam coming from inferior side. So we have a a non-coplanar beam, and then another one can come from down here. So again, adding more beams. And with this, all right, with this, we go back here. I don't have much in terms of actual presented slides because it was a live session. And I want to say thank you for your attention. If you have any questions, we're out of time. Again, this week we're also out of time, but if you have any questions, please send them to your RCC coordinator, and then they will field them to me. Any burning comment or any burning questions? I think we have time for just one question, one burning question, Kaylin, I'll leave that up to you.
Yeah, if someone wants to raise their hand to go ahead and unmute, feel free to ask any last minute questions.
I saw a message directed to me, mention something about feathering, please. It is outside the scope of this presentation. So feathering is a technique we use for craniosspinal irradiation to take into account uncertainties in positional setup. That by itself requires maybe 15 to 20-minute discussion. Maybe we can have, coordinate with your RCC liaison, and, we can see if we can have some time for that as an extra session. Any other questions, please do send to the email you see here, training@rayoscontracancer.org.